says preparing to live stream the meeting.
And we see it. Let me see who you're live as though. Because usually I get an alert when HCA goes live. Okay, yeah, we're there.
Are we on the HCA-LA page?
Yep.
So then I think nice, this is great. So I think then the last thing we should do probably is me to get off, and then will you like text me and up check that everything doesn't all collapse?
Okay, well, Erika's the host now. Erika, can you make me a co-host?
It's me to get off, and then will you like text me and up check? Yeah.
So.
Okay, well, Erika's the host now. Erika, can you make me a co-host?
There's a weird feedback thing happening, guys.
Are you on the Facebook page right now? Because if you have to mute the Facebook page. Okay,
so I'm not. Hold on. First, I'm gonna make weird feedback thing happening, guys.
Yeah, you just have to mute the little what am I saying? The box. Oh, look, we've got captions being auto-generated. That's nice.
That is nice.
So Ryan, I'll give you, one of the things I wanted to bring up was a question that had been coming up a little bit more frequently, which was the just transition. And, you know, nobody really knows what just transition means beyond what is written. But then when I went looking at like kind of just transition, I saw that through, there's a just transition roadmap being made due to the carbon neutrality and like, you know, the climate stuff. And it's due to the roadmap's due to be given to the governor in next month, or actually no, July. So that's just something I wanted to talk about a little bit because it's come up in like, I think 3 different spaces as we've been talking about this, like what happens to the insurance company workers. And, you know, just transition is written into the bill, but not detailed what it is and how it will look like. And my thing would be like, well, we kind of don't know what it looks like until we pass the bill. But if you have any insight on that, that would be great. Whenever that kind of flows in the conversation today.
Yeah, and I have an answer about, I have an author's intent answer because I know what the intention of that clause is, which is essentially give people who work in that industry a choice. They can retire early and have retirement benefits. They can have wage replacement while they go through, while they learn a new trade. They can have priority when it comes to administrative jobs in the new system. The idea being is that there's this money set aside, and whatever each individual worker decides they want their path to be, that fund would be made available for that purpose. Now, obviously that's not codified in the bill, but that's the author's intent. So obviously that's different than it being legislated. But.
Right. Hey, Erika, so in the participants, to make me a co-host, just look at my name, like pull up the participant panel, and then you see where it clicks more, and you should see the option to make co-host if you're the host. Got it.
So let me say goodbye, but would just text me that everything is okay. Like I'm not going anywhere. So if I need to get back on, I'm not going anywhere right away, certainly. So if I need to get back, okay. But have a great office hour.
Thank you. I think we're good. I mean, we're still showing live. I mean, whoever's watching is watching our pre-show. This is the live pre-show. This is a pre-show. And so I think you're good. Enjoy. Have a good one.
Yeah. Oh, this is everybody out there in pre-show land. Ooh, is this going to be a good one? The incomparable queen host of pre-show land office hours, Jeanna Harris, with special guest Ryan Skolnik, organizer extraordinaire, single payer maven, unparalleled. Ryan Skolnik from CNA, organizer for CNA, single. It's gonna be fantastic.
Dr. Ron, I think you're gassing me up way more than I deserve, but I do appreciate it.
It's actually not true. But
it's not true. We love you, Ryan.
There's a great amount of statewide respect and beyond for you, and I am one of the respecters. But and me and many others. Okay, and love you all. Thank you. Have a good time.
Bye.
Bye. The recording stopped. Maybe you can fix that.
Yeah,
Gina,
we can
since you're
record. I
host.
mean, do we want to record this, or are we just okay with the live?
No, I don't know. Good question. I guess since it's live, it doesn't matter.
Yeah, we'll just do it. I don't know. I can't remember if Ron does it or not, whatever. So yeah, I think that was one of the things I was thinking about, Ryan, was just this just transition. And of course, you know, with me being kind of one of the people that may be more directly affected by it if I don't find a new job, you know, soon, then, you know, I definitely would be interested in not only like helping paint that picture a little, you know, with a little bit more accuracy, but since, like I said, I'm in it and affected by it. But, you know, making sure that, you know, we all get a kind of a fair shake here. Because, I mean, even with what I do, you know, my side of the case management, that is done inside hospitals too. It's just that, you know, the insurance companies, medical groups, managed care organizations, whatever you want to call them, utilize us for more of that profit-driven side than the hospitals, which are more just coordination of care. So, you know, my role can flow in and out. And I do think you do need more, you're going to need that care coordination, regardless of whether it's single payer or not. Because, you know, people, the system, no matter how, if we make it simple on the payment side, it's still a crazy system if you don't know how to navigate it. Sometimes people just need to be told when their appointments are. Like they just need to have that reminder, or when to fill your medications. You know, they sometimes, like, especially with low income and low, you know, the socioeconomic problems, patient navigation is key. So like I said, those roles can definitely be absorbed into single payer world and actually be integral to making sure things run smoothly. And that's how I look at it. Now for, you know, utilization reviewers and stuff like that, I think that there's a role too, because you still need utilization review, but not in the sense that it's coming from a profit-driven narrative or guide, you know. More so, you know, just the people, like it says written in the bill, looking at those claims, making sure it's on the up and up, that you're not getting gouged, you know, all that stuff. So there's going to be a lot of good transition. It's just that how that, I guess the timeline is what's more important. It's like, you know, how much of a gap will there be? And, you know, from the initial kind of start of it to how, like, you can't just absorb everybody at once. So that's kind of something too. But anyway,
I will say really quickly that when I hear care coordination, this is just because this is how it's colloquially been used lately. When I hear care coordination, I immediately think capitation, which have kind of become synonyms these days.
And that shouldn't be the case, because when I say care coordination, I'm literally saying the coordination of care.
Right.
And
rather than these managed care plans in Medi-Cal where you have capitated payments and you're transferring risk. Yeah, we're pretty strongly opposed to that particular portion.
Right, and that's where you have to separate that language, because truthfully, in my world, care coordination is exactly what it says: the coordination of care coordination. But capitation is its own monster that deserves its own little world in capitalism land. So that's where I'm like, yeah, I kind of like when I was reading AB1400, it was kind of like I kept those words kind of, they did kind of flow and mix, and I'm just like, well, that's not how I apply that, but you guys are applying it a little differently. But
because that's how legislators use the phrase care coordination. It typically refers to managed care plans under Medi-Cal, which is why AB1400 kind of changes how, like, kind of addresses it from that angle, because the way that care coordination is colloquially used in the legislature and in terms of our current system is managed care and all of the capitation that entails. So I agree. I think care coordination itself, in the sense of actual care coordination, there will definitely be the need for that as far as a just transition goes, especially people who have experience with that. And a lot of people in administrative roles probably have some colloquial experience doing that, because you have the integration of paying and of payments and the administration of care under these managed care plans. But I do think that we should be careful there, because again, I want to make sure that when we say care coordination, we're referring to the same thing. So that's kind of why I want to do that.
So I will try to just say the coordination of care versus, you know, like coordinating patient care and patient discharging, so that because like I said, I'm coming from the nursing world. And I mean, don't get me wrong, even a lot of what the people do for managed care, like myself, it would be fine if we weren't directed to do it for the sake of profit. You know what I mean? Like that's where the inertia in the system comes, is that we have to slow down to look at, okay, what's more profitable, what's more cost effective, et cetera.
Guys,
and this is good conversation for,
just to let you know, yeah, we have 1 minute till we go live. So be prepared, you know, to talk about this again and to really break this down, because I think what you guys are talking about is really important and a huge thing that gets misunderstood. And more importantly, Ryan, as you pointed out, you know, co-opted. And so, yeah. And it's 5 o'clock. Gina, you're on.
All right. Well, welcome to our CalCare office hours. Don't ask me which one. I think this might be our 10th one. And so today we're going to have a very special guest with us from CNA and, you know, fellow brother in this fight. We have Ryan Skolnik joining us, and I'm very excited for this, because now we're really going to get into CalCare. You know, we are going to get into this bill. We're going to ask some questions. And if you've been watching while we've been working out the technical difficulties, if you've been kind of paying attention the last 10 minutes or so, Ryan and I were starting to go down the rabbit hole of a very good conversation, but we're going to continue that conversation. So once again, I want to welcome you to our CalCare office hours hosted by PNHP and Healthcare for All Los Angeles. And I want to thank you guys for joining us. This is a program that we are putting on to educate the community, to educate other activists and our legislators about this bill, what it is, what it's not, how we feel. We are all kind of strong single payer advocates, and we know we are breaking this down kind of line by line, talking about how it applies, how things work, you know, eliminating confusion, which is very important. And so I want to get right into it by going over our 7 basic principles. And I almost feel like Ryan should go over this since you're CNA. But Ryan, what we do is I share and go over every Sunday. We go over our 7 basic principles of CalCare, because it's probably the most to digest on this. So I'm going to share my screen with our 7 basic principles here. Sorry, it's asking me to do the settings. Oh, good Lord. All right, so here's our 7 basic principles. And since we have a CNA organizer on, I'm going to let you go over these.
Sure thing. So for some really quick background, these principles actually preceded the specific bill, AB 1400. When these principles were drafted by the organizers at CNA about the concept of CalCare, this is what we envision a true universal single payer system to look like. These are the fundamental aspects of a single payer system that AB 1400 has and any real single payer bill should have. And these 7 principles, you can see them on Gina's screen over there, but I'm going to go over them really quickly one by one. The first one obviously is universal coverage, and I want to qualify that by saying universal equal coverage. No tiered care, no favoritism based on who can pay more, because we know that that doesn't work. Universal coverage for everyone. Everyone has the same high quality care regardless of all the different factors that are currently used to prioritize care for one group or another. Everyone in, nobody out. Number 2, a single public program. You hear a lot of people ask, well, what if we just gave everyone who don't already have health care, but allowed everyone else to have their own plans? Well, then you have, one, you don't get the cost savings from eliminating fragmentation, but you also introduce tiered care, where if someone can pay more money to have their own private plan, that get priority, that drives up wait times for everyone in the public plan, and you create an unequal system. You see this in a lot of countries that allow this, like the UK. which is why we have a single public program, a single publicly funded payer, no fragmentation, one plan to cover all. Number 3, fully comprehensive benefits. Even if you expand coverage to everyone, it doesn't mean a whole lot if that coverage isn't that good. Like the ACA's essential benefits, they're not that good, especially when you compare them to the rest of the world's healthcare plans. So when we say fully comprehensive benefits, we mean all necessary care as determined by your providers, meaning your doctors and your nurses, not insurance company bureaucrats, and contrary to what some people may say, not government bureaucrats. AB 1400 specifies that the ultimate authority on whether care is necessary or not are your doctors and your nurses. That's how a real healthcare system ought to work. Next, freedom to choose your care provider. People like to talk about choice in our healthcare system. And those of you who are on the Healthy California for All Commission kept talking about how we have to allow intermediary plans because people like choice. The reality is people don't care about who pays for their care on the back end. That's irrelevant to them. What they care about is, can they see the doctor or nurse or facility that they want to go to? The true choice is, how and where do I get my care? That is what single payer offers, as opposed to right now, where you have in-network and out-of-network, where if you see certain providers that aren't covered by your insurance, you have to pay for it all yourself. Under a guaranteed system like CalCare, you can see any practicing provider, which is essentially all of them. Next, free at the point of service. True universal care means no barriers to entry. In every instance of cost sharing that you add, makes it another impediment to getting the care you need, which is why under a true universal single payer system, you have no co-pays or deductibles. You don't have any payment at the point of service. You arrive to the doctor, you show them your medical card, and you get the care you need as determined by your provider. It's that simple. Next, and we will definitely be addressing this particular point in more detail on this in these office hours, a just transition. The bill mandates funding and programs to protect and support displaced workers in the insurance industry, which is very important because we're not going to lose sleep over rich healthcare executives losing their cash cow in our current broken system. But we also believe that a transition to single payer shouldn't punish your average worker. So there will be a just transition for those people. And then finally, patient care based on patient need. I'm sure Jeanna and I will be talking about this one as well. Under our current system, there are a lot of financial incentives to move to less care for patients. There are financial incentives to reduce the amount of care patients get, which puts them in danger, especially for high-risk populations. Under a guaranteed single payer system, there are no financial incentives to avoid necessary care. You eliminate value-based, risk-based payment models, and you make it to where the ultimate duty of a provider is not to think about the bottom line. You make the main issue patient care first, and that's what CalCare will do. And those are the 7 principles of CalCare, and they're very important because these are the principles we're fighting for. We're not just fighting for a piece of legislation. We're fighting for an idea that these things represent, that everyone should get the care they need comprehensively and without any barriers. That's what we're here to talk about today.
Thank you, Ryan. You know what's so great is that I don't even have to talk to Ryan on a regular basis, and we're aligned because we explain the basic principles almost identically. So that's what's so cool. And that's why I think it's going to be great to have a great conversation. But, you know, I want to say thank you to those who are joining us, and hello to everyone from Facebook and PNHP land. If you guys are just joining in, welcome to CalCare Office Hours. And we were just reviewing our 7 basic principles of CalCare, AB 1400. And so what I wanted to do is go ahead and kind of go back into this conversation, Ryan, you and I were having during our technical workout that I think is really good, which we haven't delved into this just transition much on these calls yet. And like I said, in certain spaces, we've had, you know, different talks about AB 1400 and just transitions kind of come up. We've touched it, but can you kind of go back and explain a little bit of what you're explaining before we got started at 5, what the just transition really is intended to mean as the authors kind of intended in the bill?
Yes, of course. And before I jump right into that, for those of you who are watching, I want to let you know that everything I'm about to tell you and more, we actually have on the Medicare for All campaign website, a series of FAQs that address a lot of these questions in a lot of the same ways that I'm going to be talking about now. So the link to that, and I'm sure it'll be posted somewhere, is medicare4all.org/about. And you can reach out to me directly if you want help reaching any of these things. But anyway, about the just transition, we want to make it, like I said during the 7 principles, abundantly clear that no worker in the healthcare industry, if you are in charge of billing, if you are in charge of administering, it's not your fault we're in a broken system. You're making a living. You shouldn't be punished from the transition to single payer, which is why the just transition is included in the bill. So the just transition that is literally in the bill, the specific language mandates at least 1% of the entire CalCare budget, which is billions because it's a very big budget, which a multi-billion-dollar fund for the first 5 years of the program to help people who are displaced or affected by the transition. Now, it doesn't specify in the bill yet what specific form that takes. That's left up to the board. But what I can tell you is the author intent. This is the same intent for CalCare that there is for Pramila Jayapal's National Medicare for All bill. And the idea, it's the same transition plan in both. And the idea is it'll do things like ensure wage replacement, retirement benefits, job training, education benefits, covering tuition if people want to go to school and learn a new trade, or if you want to continue to do the same kind of work, possibly priority hiring for the new administrative jobs that will be required to administer the CalCare program. So the main thing I want to emphasize, the primary premise of this transition plan is choice, because every individual worker in the insurance system that we have right now may want to do something different. You may have been doing it for 30 years and you've decided enough is enough. I want to retire a few years early. That can be done. The fund can be made available to help with early retirement payments. If you want to say, I don't want to do healthcare anymore. I've always wanted to, I don't know, sell skateboards on the pier at Pismo Beach or something. You can go to school to learn about skateboarding. Obviously, that's kind of a joke, but you get the point, is that if you want to go to school and learn a new trade, tuition can be covered there, as well as wage replacement while you're going through that process. If you want to continue to do the exact same work because you're comfortable where you are, those jobs will still exist under guaranteed healthcare for all. They just won't be in the hands of private insurance. So the idea here is that the fund will be made available and it'll be flexible, meaning they'll work with you to figure out the best thing to do for your specific transition. And I know that it's a little hard to fathom that since it's not codified in the bill, that it'll be this comprehensive, but this is truly what the intent is. Because and that's why, by the way, it's a little bit more vague in the bill, because we don't want to say it's for these specific things, and then people will be like, well, what about this? And it'd be a perfectly great alternative that isn't in the bill. It won't be an option because it's not in the language. So it's best to allow the board to work with people to come up with the best solution. And by the way, before I pass it back to Gina, that's kind of the reason why the bill is written the way it is. AB 1400 is much more detailed than SB 562 was in terms of what the board does, but they still use the same generic structure of having a board in charge of administering the program and giving the board wide latitude to do that, because you want there to be flexibility to respond to sudden changes, and you want to make sure that any policies implemented reflect the current reality as opposed to the reality that exists when the bill was passed. So I think that the way that the bill is written ensures maximum flexibility while ensuring there's plenty of money to take care of everyone who may lose their job due to the transition to single payer.
Thank you, Ryan. Yeah, I mean, just transition is something that, like I said, I'm definitely interested in just because I know I'm going to be affected by it. And so, since you brought up the board, one thing we were talking about, I believe last week, and I'm like, I believe it was last week, I still live in this pandemic kind of like a wormhole of time in a sense, but the board composition, we were looking at the fact the governor gets to appoint so many seats and then the speaker of the assembly. And, one of the things that I think brings concern to us is that with the board having so much power over this system, it kind of worries me that if the wrong people get appointed, what would that happen? Now, on the other side, and I want to point this out to people on the other side of this is also a good selling point for the people who are on the fence, the elected officials who are not sure, because, you know, one thing the board does have the power to do is to say yay or, you know, nay, we can build this out. And then if it's like, you know, they can say, they give that final okay. And so, you know, but what is, you know, from the CNA side, from your point of view, and I know those are can be two separate things. So I don't want to say CNA and yours, but or yours. What are your thoughts on the composition of this CalCare board?
So
sorry to interrupt you guys. I think I'm getting feedback that we popped off Facebook Live, even though it's
I'm watching it right now.
Okay.
Yeah, I'm watching us live right now.
All right, keep going. Thank you.
Mm-hmm.
Yeah, I'm looking at it too, so I think it's okay. So first, let me clarify that these are my particular thoughts. I'll specify throughout this conversation if I'm speaking as, hi, I'm from CNA, or hi, I'm Ryan Skolnik, and these are my thoughts. Right now, I'm Ryan Skolnik. And my thoughts on the board are, yes, the board is incredibly powerful. And I think that it's a valid concern, but I also think there are a lot of advantages to doing it this way. I think a major advantage of doing it this way is that you obviously have more flexibility, but also you have safeguards that are built into the bill. Specifically, and this is probably one of the most, if not the most important clause in the bill, the single most important clause. There's a lot of important clauses in the bill, but this one does so many different things, and it's very simple. It is the override provision. So the override provision is what tells Jeanna, tells Dr. Bill, tells whatever healthcare provider there is that they are the ultimate authority on what care is and isn't necessary. And that's an important safeguard, because if you have a rogue board that decides to say, well, we don't consider abortion to be reproductive care anymore, so we're not going to pay for it because we don't consider it necessary care, then you have Jeanna and Dr. Bill or whoever that says, you know what, we think that is necessary care and our patient agrees with us. You two win. And I think that's important. And it doesn't address every issue, of course, because the board is incredibly powerful and they are going to have the ability to set a lot of policies regarding how the system works. And Jeanna just alluded, there is legislative oversight over that. But of course, if they got on there, that's probably not going to help as much. But you're basically looking at the risk of the pro tem, the governor, and the speaker all becoming hostile, or at least two of those entities, which doesn't look particularly likely at this point, given the state of California. I'm not saying it can't happen, but it doesn't seem particularly likely that we're going to have rabid anti-single payer people in those positions that are Republicans, of course. And once the system's implemented, we know what it looks like when people try and sabotage a popular public system. There's a reason why George W. Bush failed to privatize Medicare during his second term. Once you have a system like CalCare implemented, it becomes a third rail. You can't mess with it. So we got to get it implemented, and then that's one of the major safeguards. But there are safeguards built into the bill as well, like I said. So I think what it comes down to is working with the legislature to make sure that the language of the board, if they have concerns in the bill, is worked to satisfy those concerns. But ultimately, I think that granting that flexibility and ensuring safeguards makes this sort of structure worth it. That's my take, of course.
Yeah. And I know that the board will also have to put together a public advisory committee as well, which hopefully will be another safeguard against rampant legislative stuff going on. But I see from Dr. Bill, he had brought up a lot of doctors and nurses. And you know what, I mean, Dr. Bill, you're here. But I just wanted to say to that point, about being retrained to care facilitating roles. I will say that one of the reasons why I am in an admin role is because of a back injury from a care role. And that tends to be quite a few of us. in this industry is that we get injured, something happens to us. I mean, some of us just want to get all the patient care, but you know, if you know patient care, Dr. Bill, you know it's not easy on the body or the knees or the back for me. And so that's the reason why. But would I love to go back to patient care? Absolutely. But you know, my back may say otherwise. But anyway, the question Dr. Bill was asking is, do we have any idea what percentage of their workforce, meaning the claims processing of the health insurance companies, would be those jobs that get to be transitioned?
I don't think we have a sense at this point because we're very early in the process, and I don't think we've done any like questioning as to what percentage, but I will say that I think it'll probably be relatively high because it's an easy transition to make. And of course, if they're currently working in the kind of job you do right now, you'll, by virtue of the transition, be some of the first people in line to fill those roles. So I guess the percentage will be whoever wants to. And I know it's not quite a satisfying answer, but it's the best I can give this early in the game.
Thanks. Yeah, and then also I do want to say I just was looking this up, and through the climate initiatives, they're building out a just transition roadmap from the Labor and Workforce Development Agency that is supposed to be due to Governor Newsom in July. So through that roadmap, that may also assist this roadmap as well, seeing how they do the just transition for, you know, people who will be affected by the oil companies and, if we finally ban fracking. And all of that. So I think that would be good to kind of keep an eye on. That, like I said, it's due next in July. So that'll be good to kind of keep an eye on, because like I said, it may help us with this, have an idea of how this may work too. And then Dr. Bill, you have your hand up?
I do. Thank you so much. So I guess my question was not so much like hands-on, clinical care as much as like, because people in health insurance have been looking at what qualifies or doesn't qualify as care, it's more like care processing. So people who have not gotten their care processed because insurance companies have algorithms and redlining and all of that stuff, it seems like they would be in a unique position to know what patients need and be able to get them what they need. So I guess you traditionally would call that case management or care management, which is kind of a bad word, but it really would be care facilitating because it gets people what they need. Make sure diabetics have their testing machines and test strips, and that they've got their education and all of that, instead of like denying them stuff, getting them the stuff that they need. I mean, that seems like a pretty straightforward transition.
So I want to, since this is exactly what I do, it's my role, I kind of wanted, the way we're broken down, it kind of, you have utilization review. Now, those are the guys who do that denial process. And then you have the case management, care management, it's used interchangeably in medical, in the hospital world. And so what I do is I make sure that I navigate the system with you. I kind of am like your kind of like your guiding light here. And yes, and like I was telling Ryan before we got started, you're going to need me because just because we're providing a single payer source does not mean that the system, that spaghetti may get a little bit cleaner, the lines may get a little straighter, but it's still a little bit of a bowl of spaghetti. And so you're going to need help navigating that. If you don't know how to do that, then you're going to get lost. And then most importantly, as a person in management, especially how I train, is that I train people that first and foremost, you're a patient advocate. You might be the only person that patient has to getting from point A to point B in the bowl of spaghetti. And so definitely will be needed. And especially, just informing people that, hey, you know what? No, don't worry about the cost. Just come to the doctor. You're sick. Just come to the doctor. That's going to take years of untraining, honestly, for people to understand that they can just go to the doctor. Now, some people may overutilize that, but for most, they're still going to feel that anxiety of, I got to pay. They're going to show up to their doctor's offices and just start reaching into their pocket because they're going to know that they got to pay something. And then they're going to be like, okay, you're good, have a seat. And so with case management, care, and Ryan was correcting me on the word care coordination, because when I say care coordination, I mean coordination of care for a patient. But in the legislative world, care coordination means something totally different. That I'm like, wait, what? And I feel like even me now, with him just telling me this, I'm going to slip up, because it means two different things. And I don't want to divert away from the questions, but Ryan, do you just want to touch on that really quick? Because I found that to be really, really important.
Yeah, so this is going to definitely help clarify things for those of you who are on the Healthy California for All Commission meeting over the last week. That our own policy expert, Carmen Comsty, is a commissioner. She did an amazing job, and we're very lucky to have her. But you'll hear that they mention care coordination a lot during there, but they don't mean the care coordination that Jeanna was just talking about. They're referring to managed care plans under Medi-Cal typically. And they include care coordination as Jeanna means it, but it also includes things like capitated payments, which, while the former AB 1400 doesn't do anything specifically against, the board would be in charge of implementing policies regarding care coordination in the sense that Jeanna means it. But the second part regarding capitated payments, for those who aren't quite as wonky, capitated payments means instead of paying per service, you're giving a certain amount per patient. As a very, very simplistic way of describing it, it's a way of trying to reduce costs. You've probably heard synonyms of value or risk-based payments. They all kind of form a really convoluted thing that is being attempted to replace fee-for-service, where, like I said, you pay a doctor based on how many services they provide. But AB 1400 specifically does not do capitated payments, which is how we've been doing things more and more under Medi-Cal in the state and other plans, because capitation payments are inherently discriminatory, because the entire premise behind them is we will reward doctors who get the best outcomes while providing the least amount of services. So that encourages people, especially providers that serve high-risk communities, people who are in the inner city, rural communities. It incentivizes them to provide less care, because which in turn hurts outcomes for these people even more, because they're more likely to have severe and often chronic conditions. So, and then of course, it doesn't even do what they're hoping it does. They've done countless studies that show that it doesn't even really save money. So it's become kind of gospel among the status quo in healthcare. Capitation good, everything else bad. AB 1400 doesn't do capitation in that sense. So that's why I want to clarify that. When Jeanna says care coordination, she means actual coordination of care. But when you see someone who's involved on the legislative side kind of be like, oh, no, AB 1400 doesn't do that. They're typically referring to the payment aspect of managed care or capitation. So I think that, I know it's a little wonky, but it's really important to talk about, because it is one of the major opportunities that single payer brings us, is the chance to halt what seemingly inevitable march to capitated payments. And I'll close by saying, for those of you who are on the commission, you'll have heard the two legislators on there, Jim Wood and Richard Pan, say that some of their major objections to AB 1400 is that it goes backwards by substituting fee for service in for capitation. And it doesn't do unbridled fee for service. There's requirements in there and policies in the bill that are intended to reduce fraud and abuse of the fee for service system. But while fee for service isn't perfect, it's certainly not discriminatory, and it does not incentivize the denial of care like capitated payments. So keep that in mind when you hear these legislators make the argument that AB 1400 is a step backwards because it reinserts fee for service. Well, they may think that, but think about the alternative. It's not any better.
So I just want to, and I see
we have a question from Facebook.
Yeah, actually, that's why I'm getting ready to touch on that. I saw it about the capitation. Are you talking about that question?
Yeah.
Okay. So capitation, as I understand it, and where I see it applied, and then I'll let Ryan, add to it as well. So let's say you have a provider and I come to you and say, provider, you have this big panel of patients. I'm going to pay you X dollars a month for these patients, right? You take care of these patients how you will. You get the same X dollars every month, right? Same pot. So what your incentive is in this capitated pot, the same thing, very similar to managed care, is that you want to ideally, okay, let me say the premise. The premise was that you would be incentivized to keep your patients healthier so that you made more profit out of your pot, right? Because you're getting the same amount of money regardless, healthy, not healthy, same amount of payment. So you should have been incentivized to keep your patients healthy, right? Well, that was a good idea. They get an E for effort. I'm giving you an E for effort, but that isn't how it worked out. So now you've got all these different capitations going and multiple different things. Let's go back to the bowl of spaghetti. Now you've got the capitation system itself alone is a bowl of spaghetti. And now you've got all these providers getting paid this money, and then patients are still sick as hell and getting sicker. They're not providing the services that they want, and the accountability really isn't there. And if it weren't for the fact I still need to keep a roof over my head, I could tell you some stories. But so that's kind of like the general, like very broad. Now I'll throw it over to Ryan, who may be able to get a little bit deeper into the capitation world, but that's basically kind of umbrella.
No, that was the intent. And that's important to understand, because you'll hear legislators make these moralistic arguments about how the way to reduce healthcare costs is to give a set amount of money. And basically, if doctors are able to keep patients healthy by spending less of that money, they can keep the remaining and split that up between their different groups. And that leads to whole conversations about ACOs and all this other stuff. But basically, the idea is that you're rewarding doctors that do more with less, in theory, with capitation. But that's not how it works out, because a lot of the formulas that are used for capitation reward not giving as many services. The idea is the better outcomes you can get with the fewest services provided give you the best rewards, because the fewer services that you provide, the less money you're spending from that pot on services. So you get to keep the rest. So you're indirectly incentivizing doctors to try and get by with the least amount of provided care possible. And not all doctors do this, to be clear. That's not how everyone works, but that's the incentive that the system is providing. And you could possibly make an argument that it's still for the best if it did save a lot of money and didn't hurt outcomes that much, but it hasn't. It hasn't done what they wanted it to do. Our system is getting more and more expensive every year while we're going through this increasingly capitated healthcare system. And now you have a system where the inequities between rural and urban facilities and suburban facilities and richer and poorer, those gaps are growing even wider. And that's something I want to emphasize really quickly about the problem with trying to do payments based on risk or value rather than based on services provided or lump sum payments to institutional providers, which I'm sure we'll talk about later. The problem with doing it this way is when you serve a group of patients that are higher risk, you have a few different options. If you refuse, because a lot of these facilities wouldn't be able to financially survive a move to capitation. There's a reason why a quarter of all rural hospitals in the United States are at risk of closure right now. A big reason for that is that if you put this burden of capitation on, that often isn't enough to keep the facility running, because one, you have patients that tend to have more high-risk conditions in rural areas. You also have less foot traffic. So if you have capitated payments per patient, you have less payments there. So you have less to work with. You have a smaller pot to work with overall. So smaller pot plus sicker patients is a recipe for disaster. So it's not the only reason that these rural facilities are shutting down, but it's a major part of it. So that, by the way, is a major counter to the anti-single payer argument. Well, you're going to cause hospitals to shut down because they can't afford Medicare rates. First of all, that's not how single payer works. But even putting that aside, the status quo is if we do not change, at minimum, a quarter of all rural hospitals in the country will be gone. So the status quo is the shutting down of our hospitals. We've lost, I believe it was a third of all of our, it might have been more than a third of all of our hospital beds since the 70s. Because as a country, because the system we have right now is so hostile to smaller facilities and more beneficial to the Kaisers or the Sutters, the bigger facilities. They've loved our current system, which is why they spend so much money lobbying against any changes to it. It's very lucrative, but it's still bad. And it's bad for the patients, it's bad for a lot of providers, and it's something that really at the end of the day benefits shareholders and executives rather than actual providers of care.
Exactly. And I mean, just to add to that really quick, is I just saw an article in New York Times about how big hospital systems use the COVID relief funds basically to help buy their whatever hospital they had in their site. So I think Barnaby in New York City used they got $500 million in COVID relief funds. 500 million, that's $500 million going to one hospital system. And guess what? They went and bought something. And I'm like, oh, so you didn't go and give your employees a raise, or you didn't go buy better equipment. You didn't stock up on PPE for the impending flu COVID baby that could be coming this fall. Okay, got it. You went and bought another damn hospital like UCLA just bought Olympia. Got it. But anyway, I do want to go back to Betty. Betty, I'm sorry. I saw you put a question in the chat and it got caught up in the long kind of like explanations people were putting. So do you want to ask your question? I think it had something to do about the fail-safes we were discussing earlier. No soldier left behind over here. So I saw it and I just want to give you an opportunity if you want to ask it.
I know, because I couldn't really explain it in a written form, I guess. And I've been sharing on Facebook. That's what I've been doing. So
thank you. But yeah,
here, usually when I'm here, I'm either sharing it on Twitter and this Twitter, that sharing it on all different groups and getting it out there so you guys can be heard to a wider audience. But my question is, in regards, we're going to be taking in tax money, regardless, whatever it is, if it's Medicare tax money, Medi-Cal tax money, whatever progressive tax, whatever it is, we're going to be taking the tax money to pay for the healthcare. A lot less than what we're paying now, I'm pretty sure. Pay a lot of money on premiums and co-pays, deductibles, and such. But I do have a question because this happened back in the Great Recession, in which they rolled out a lot of programs to help people, like, okay, so you lost your home, you lost this. So we're going to roll out this Keep Your Home America that becomes Keep Your Home California. They hire a private or semi-private organization that middlemans it and takes all that money that's supposed to be the social benefit to help people get back on their feet. And then they never get the funds to the people and or they short fund people. And it's actually happening right now. I'm not sure if it's Michigan or something else, where they did put the rent relief because of the pandemic in the hands of like a middleman type or quasi middleman. And they just are not getting the money out to the people that need this rent relief. So my question is that how is there something in the bill that ensures that it won't go to this kind of quasi middleman? Like all of a sudden we say, okay, we're going to get rid of all insurance companies, but since Blue Shield has been doing that really well and they've been a nonprofit, then we're going to give it to them to distribute the money, and the money to me is the healthcare, the money to the healthcare. So that how does that is there a fail safe in the bill? Is it not structured that way?
Basically, if you're not actually providing care, you're not going to get a payment from the single payer system under CalCare. So that is actually a major difference between SB 562 and the current bill. You could call it the Kaiser cutout or whatever it may be. This bill is written to ensure that if you are an entity that tries to receive money and then distribute it to healthcare providers on behalf of the system, that's not a thing, because that's the antithesis of what a unified single public program is supposed to do. eliminating that bloat, eliminating the middleman, a direct payment from the system. So no. So basically the bill, yes, the bill is written in such a way to ensure that a participating provider needs to enter into a participation agreement with the board to become eligible for payments under CalCare. If you are an institutional provider, meaning you're a hospital or whatever, you get paid via what's called a global budget, which Jeanna and I, I'm sure we'll talk about later. If you are an individual provider, you have your own practice, which is unfortunately becoming rarer and rarer under our current system. You have a choice between either fee for service with the fee schedule based on Medicare as the baseline, or you can accept a salary. But those are direct payments from the system to the providers. There's no benefit to a middleman in this sort of system. It just creates more bureaucracy because then you need to have the system keeping track of where payments go, and you have to have auditing. It creates more bloat. It doesn't actually help care. It doesn't actually increase the quality of the system. It's the wrong kind of choice. So that's a great question, Betty, and I'm glad you mentioned it. And that's why AB 1400 is considered the gold standard of state single payer bills, partially because of this reason. That's not going to be a thing under this bill.
That's one thing that it is straightening the spaghetti on, from provider to payment, and not provider to insurance company to Jeanna to go have her boss clear it, to go have their boss clear it, to go make sure that we can somehow skimp CMS guidelines on it, to make sure that we can get the best profit, to do this, to that. It's just going to go to the provider. Anyway, Maureen, you have been waiting. Thank you so much.
Yeah, no, not at all. It's good I waited because I see Ching Sim and I are on the same plane there. One of the promises of global payments in a single payer system is freedom of choice, is freedom of the patient having the choice. And that does a couple of things. Number one, it gives patients control over their own health care. And the other thing it does is it allows for a real competition of quality, right? A competition, although I think most people will go to wherever's convenient once clinics and hospitals open up, but it's a competition of quality. People are not trapped in any kind of membership program. And when you have capitation, you have to have membership. That removes, it seems to me that removes a patient's choice. They go to one doctor and they say, you know what, I don't really like this. I want to go somewhere else. You know, in Kaiser, you have to stay with Kaiser and you stay with the Kaiser physicians, but maybe you heard there's a specialist at UCLA. Well, if you're in a capitated program that has membership, you can't. You have to stay with your program. And it is inherently discriminatory to have a system, I believe, where, you know, there are differences, like somebody's in this program or that program. It is, every patient should be able, every human being should be able to walk into any physician's office and look the same. We are the same. We're not part of this program or that capitated HMO or IDS or ACO, that we are the same. So it just seems to me that capitated budgets remove choice from people and also apply on some level a label that you are kind of the property of this particular HMO or ACO. So I don't know, correct me if I'm wrong, Ram, but it just seems to me that's one of the promises of AB 1400 is that you have freedom of choice, and capitation removes that.
Well, not only is it freedom of choice, because that's definitely true, but it also is a matter of eliminating healthcare tiers. Even within the different systems, the amount you pay for your plan determines the quality of your care. I've seen, there's a reason why one Kaiser member will complain endlessly about how terrible it is, and another Kaiser member will rave about how amazing it is. It's often when they're from the same going to the same facilities. It's because they will prioritize you. They have the ability to prioritize you based on how much you pay for your plans. So there's discrimination within the capitated group as well. But yeah, it's also true that if I'm with Kaiser, I can't go elsewhere. And that, I think, is the important thing to message to people who are worried about what this bill would do to Kaiser. the way I describe it to people is, imagine a world where you could go to a Kaiser facility and stay solely within their network. But then the moment you find a specialist outside the network that fits your needs better than what Kaiser itself offers, you can go see them and get it fully paid for without punishment. And then you can come back to Kaiser if you want, or you can stay out. Whatever is easiest for you. Because ultimately, what we're doing is we're separating the payment and the provider aspect. We're removing the payment responsibilities from all these fragmented entities, which of course includes these managed plans like Kaiser and all of that. And if they want to, and if they have their own facilities, they can continue to operate. They'll just get their money elsewhere. And yeah, that will lead to true choice. Because if I like Kaiser and I like my Kaiser doctor and I like the facilities they offer and I like all that, I can stay solely within there if I want to. But then I can go elsewhere and have it fully paid for because it's not Kaiser paying for my care anymore. It's the single payer system. So yeah, Maureen, I think that's absolutely right. It is about choice. And I mean the choice that matters. Nobody cares who pays for their healthcare on the back end. They care about who provides it, and they care about choice with that aspect. And that's what single payer is about, true choice.
Exactly. And I mean, and just to say, this is the part of the, where you get into the tier system, that's part of the medical apartheid. Once again, it is a tax on being poor, and being poor should not be treated as a crime. I should not be criminalized because I wasn't born with a silver spoon in my mouth. And, you know, while I may still go to school and things like that, I should not be criminalized by this, you know, kind of racist systemic thing that has grown into what we call the United States of America. Anyway, don't get me started on that topic. Erika, what's up? You got your hand up.
Yes, because I have two questions from Facebook. I will start with the first one from Chris Shimizu. How would AB 1400 save the rural hospitals? Won't they still have the low foot traffic? So how would fee for service save them or bring them back?
That's an amazing question. Oh, sorry. Go ahead, Jeanna.
Oh, no, I was literally, you know, you're the guest. Feel free to go. I'll come in after.
Okay. I was just going to say that institutional providers like hospitals don't actually receive fee for service under CalCare. They'll receive what's called a global budget, which is a lump sum payment to a institutional provider to cover all of its operating expenses for that quarter. These global budgets are tailored toward each specific facility's needs, factoring in things like how many patients it typically sees, what the common illnesses in the community that they serve are, what equipment they have on hand, what their typical operating margins look like with what they currently have now. So each budget is different and tailored toward that specific hospital. Now, why is that important for rural hospitals? Well, because under the current system, you have a situation where lack of foot traffic combined with the way we're financing care right now has led to rural hospitals being financially pressured to the point where they're shutting down and often being bought up, like Jeanna talked about earlier. What a global budget means is that you can tailor that specific budget to that particular hospital, saying, okay, you typically see this number of patients, they typically have these conditions, they typically require this much follow-up, et cetera, et cetera, et cetera. That ensures that they can stay open and continue to provide care without worrying to that extent about their margins, because that's what the budget's based on. And then you have other fail-safes as well. You have special projects and capital expenditures budgets that are intended to create separate funds to allow facilities that are under-resourced to upgrade, to modernize their equipment, to hire more staff. The basic, and they'll be given based on need, not based on who has the biggest lobbying power. So if you have a rural hospital, which is likely using an MRI machine that's 50 times as old as the one in the Bay Area's Kaiser, they'll have extra money on top of their global budget to upgrade those facilities. So it stabilizes the financing of these particular hospitals and allows them to stay open. And that's really important because people like to argue that single payer would force hospitals to shut down. In reality, a global budget is one of the most effective tools we can possibly use to end the hemorrhaging of our hospitals. And that's one of the major benefits of AB 1400.
And I just wanted to add to that. So about rural healthcare, you know, one thing about community health nursing population or public health nursing, which Maureen, I'm sure she'll smile on this one, is that you can send public health nurses. These legislators can utilize us to do community assessment. So we can go into rural California and see where there's need. The reason why there's low foot traffic in the hospitals of rural California is because they can't get there. It's just not, you know, if your hospital is 50 miles away, you can't get there, you can't get to it. And so having this ability to do these assessments, to look at where we need care, you might not be able, I'm not saying we're going to put a hospital in every single small town, but maybe a clinic. You know, there's so many small towns in rural California that don't even have a health clinic, not a place that they can go to. They depend on community, nonprofit organizations to bring a trailer to their town to do their care maybe once a month. And when you have a chronic diabetic, when you have chronic hypertension and chronic conditions, once a month may not be enough. So with AB 1400 and the way that these budget allocations are going to look like is that we can start providing these resources maybe to put a community clinic in that town. And then, you know, they'll be able to determine whether they need to escalate to the nearest hospital. There will be more hospitals. So maybe instead of 50 miles to the next hospital, it might be only 10, which may be more feasible to provide access to care. Not to mention, rural areas are a focus of Healthy People 2030 on the national level. So with AB 1400 passing, we would actually be able to help possibly hit our targets for Healthy People 2030, which we did not hit for Healthy People 2020. So I just wanted to throw that in there from the nursing public health kind of perspective. But I know I want to keep on moving. So Erika, you said you had a second question too?
I do, but Chris actually has a follow-up question on this. So I think it would be, if it's okay, I'd like to ask her follow-up question. Who would determine which hospitals get how much money? Is there a body that would devise a system to figure this all out? And would they be elected or something?
That's an excellent question. It's the CalCare board. So under the current system, let's talk about, for example, a typical fee-for-service arrangement, where a doctor would negotiate with a payer for rates for a given service. Think of that on the scale of a global budget, where the representatives of an institutional provider will negotiate with the single payer system for a lump sum payment, where the facility will go to the single payer system and say, okay, here are metrics here's what we're requesting, and here are the metrics we're using to justify that. And it'll be a negotiation back and forth, and that will ultimately determine the amount of the global budget. And there is an appeals process built into the bill as well if they feel it's too low. And there are provisions for emergency funding in the event of something like COVID or another public health crisis. Those budgets can be adjusted mid-quarter if need be. But the idea behind a global budget is that it adds a lot of transparency to the process, because that's taxpayer money being used to fund the operations of these hospitals. And that comes with a lot of stipulations. For example, the bill specifies that you can't use that money for marketing. You can't use it for political lobbying. It has to actually go to healthcare. And you can't do it. It can go to salaries, obviously, for those who provide care, but it can't be used for massive executive compensation packages. So when you have a system of public negotiation between the provider and the institutional provider in the system, you add a lot of transparency to the process, and it makes it easier because they're going to have to provide evidence for why they're requesting a certain amount of money in order to get that approved, as opposed to now, where nobody seems to understand where rates come from. They oftentimes see unbelievably arbitrary. Anyone who's ever received a surprise medical bill will wonder why the hell one operation will cost $5,000 and the same operation from another doctor at the same facility will be like $7,000. This current system makes no sense. So that's another benefit to the global budget. I think that's a really good question, because it gives you the opportunity to talk about what the process is, and more importantly, how it will be beneficial. We chose global budgets for this particular bill because not only is it a way to stabilize hospital, but it rectifies a lot of the systemic issues in our healthcare system, and specifically when it comes to financing of institutional providers.
Yeah, and that's why I call it a health equity bill. Erika, I know you have another question from Facebook, but I want to go to Chang Sim just because she's been kind of waiting for a while. Chang Sim?
Yeah, I have a follow-up question to Betty's excellent question. Because Ryan, you said that there's no middle man between, the board and the provider. So that's understood. But you also had said that the board has a lot of power and they have a lot of flexibility. So, you know, do they have the flexibility to, you know, have a middleman, not on the provider end, but administrative end? You know, because that was not clear to me in your reply to Betty. Like, yes, it's very clear the bill proscribes any kind of, you know, having a middleman, you know, between the single payer and the provider. But what about the administrative side?
I just want to add, thank you, Chang Sim, because that's actually what I was asking. I was asking if we take our tax money in. We take our tax money into the state of California. Who is distributing that money to the providers? You know, where's the distribution happening from there? I know it's going to go straight to the provider. We hope that that does. But is there any possible way that there could be, like, for example, a Blue Shield? Oh, Blue Shield has the expertise in this. We're going to hire them to do this. They're not an insurance company anymore, but they're the ones that are going to get the money out, and they're going to take a chunk of it to do it.
That's a really good question.
I'm not saying they are. I'm just saying, is there something in this bill that says they're not?
Oh, no, that's a very, very good question. So the answer is, and I know this is going to be entirely unsatisfying, but we'll see. And here's why I say that. The board does have the power to contract for the purpose of doing its job. However, the intent right now is that it would be direct payment from the board and whatever system it sets up to these providers. Now, I certainly hope that the future isn't that we're giving money to Blue Shield, who takes a cut of it and then distributes the rest, because that doesn't actually improve anything, and that's what it would inevitably become. But the bill does say that you can contract for the purpose of the program, and that makes sense because there are things like education, public health education, community messaging. It may make sense to use system dollars to advertise, hey, this program covers this in an area where there's a lot of instances of people who are high risk. So I will say that in theory, I suppose it's possible, but the intent is that not to happen. So I guess we'll see what happens as that goes forward. But I know that as we go forward, those who are pushing this bill are going to do their best to make sure that the vultures like Blue Shield do not put their teeth into this system, which is why the bill is designed to remove one of the main ways they could have been involved before under prior single payer legislation. That was an amazing question, by the way. And I do have to say, I love conversations like this because I love going into the weeds about this stuff because it's truly egregious at a systemic level, just how many broken aspects of this system exist. And it's interesting to talk about the different real solutions, the conversation that our opponents like to say we're not really having. You've heard the likes of Jim Wood and stuff saying, well, we're not talking about so-and-so. No, we are talking about it. That's what you all are doing in these office hours. It's just because they're choosing not to listen. That doesn't mean these conversations are going. So I want to thank you all for putting this on, and again, for having me, because this is a great thing to be part of.
Yeah, and we put the invite out there to all the legislators all the time. I know Erika has added them, and we at them all the time on Twitter. They know they're more than welcome, and we're not coming from a point of attack or anger. We're coming from a point of we want you to understand. And I think that is something that they don't understand, is that yes, we're angry and yes, we're pissed off because we're seeing so much pain and suffering, but I want you to understand from this point of view because you may not have that experience to understand it. And it's okay. As a legislator, you got to understand a lot. I feel you, I get it. But at the same time, don't make decisions based on limited or misguided information. But Betty, also to touch on what you're saying about outsourcing certain things, it may have to happen, yes, like what Ryan said, but here's the thing, they can't upcharge. If they, let's say for whatever god awful reason, the worst case scenario, they did decide to use some type of mechanism, some methodology that Blue Shield uses, right? But they can't upcharge the CalCare rates. The CalCare rates are the CalCare rates. So they can't sit there and say, well, we got to also have this admin fee. Well, sucks to be you, make it work. So that's one thing that they cannot do. So even if there is an outsource, because I can see that happening, because yeah, there's going to be a lot of people who they're not going to know. And yes, these companies have gotten it down to a science. They just are greedy with it. That's the problem. They charge whatever they want with it. So when CalCare says these are your rates, they can't go outside of those rates. They can't sit there and fluff and pad the executive budget. They can't give an executive bonus for landing that contract. That really kind of limits, it cuts a few heads off the Hydra. It doesn't cut all the heads off the Hydra, it cuts a few. And like I said, that's the worst case scenario that I can see right now. More to come on that. But I know, Erica, you had a second question, and then I think I see there was a comment from Lynn, had a comment after that. Sorry, a lot going on in the chat right now, so I'm trying to keep up. Go ahead, Erica.
Yes, I love this question. I'll take the first stab at answering it, and then I'll turn it over to you and Ryan. Ali Reza on Facebook asks us, what's our plan to get the word out about CalCare? And so Ali Reza, thank you so much for that question. And to everybody out there, I would invite you to go to HCA-LA.org. That's us, Healthcare for All Los Angeles, HCA-LA.org, and click Take Action. We have a whole Do You CalCare page, because we CalCare and we want you to CalCare. And on that page, we have an action plan. We have things you can do on your own. We have an events calendar, things that you can join us with. We have a volunteer sheet so that you can sign up to be a volunteer with us or an ally. And we also have on there the CNA toolkit. So we have everything on there of how you can help get the word out. We are developing speaker training sessions. So really, Ali Reza, I would love for you to fill out the volunteer form and have you join us. We're having ledge visits. Gina heads that up. And also mark your calendar for July 24th, because we will be taking the streets, and we want to take it in the thousands. You hear that, Dr. Bill? So you got to get PDA to take the streets with us. Mark your calendars, July 24th. Come to HCA-LA.org. We'll keep you informed there. But I want to turn it over to, and of course, we're always supporting everything the nurses do. That's why we have their toolkit on our website as well. But Ryan, do you want to add to that?
Yeah, first, if you have the opportunity to work with Healthcare for All Los Angeles, do it. They're amazing activists and they do a lot of really great work. So I want to give them all the credit in the world. On our end, we are shifting more, because we're still going to be doing community outreach, but I also want to talk about a new aspect of our of what we're going to be doing as we go forward. And we're still in the process of preparing all of this stuff, but we plan on a lot of educational webinars and quote unquote class type things as we go forward. And for those of you who joined us in early 2000 for our series of COVID webinars, the educational team at CNA NNU put together these amazing webinars where they talked a lot, they went really into depth about the science, about the intersection of COVID and climate change, of our healthcare system, racial justice, all sorts of amazing connections that people might not have realized existed between the pandemic and other aspects of our society that need to be fixed. We have a bunch of trainings planned for every level of activist. If you are a new activist to CalCare and you've never gotten involved before, we have intro trainings on both CalCare itself and on how to organize. For those of you who have been doing this forever, as I'm sure most of you who are watching this have, we're going to do deep dives on CalCare policy. We're going to do trainings on power mapping your districts. We're going to talk about the California legislative process. We're going to go really in depth about how a bill moves forward, the different pitfalls, how to put a bill through a committee hearing, how the legislators typically try and kill a bill, the best ways to advocate. We're going to go really in depth about that. And then finally, we're going to do, as far as the advanced trainings, we're also going to talk about what happens after CalCare passes. We're going to talk about what the board's going to do, the waiver process, potential opposition and things we may have to deal with after the bill gets signed into law. We'll talk more about the just transition. So we're planning on having something for everyone. And then finally, we're also going to be doing quote unquote supplemental trainings that are more akin to what we did last year with COVID. We're going to talk about the healthcare industrial complex. We're going to talk about structural racism and bias in our healthcare system. And we're hoping to even expand our Medicare para Todos campaign, which is outreach about single payer to the Latinx communities of California, and hopefully doing trainings on that level too. So we think that this is a great time to expand public awareness and also to inoculate. That's something that's going to be so important because we know exactly what's going to happen once CalCare is signed into law. The insurance companies and the drug companies are going to put a ballot initiative on the ballot to not only repeal it, but they may even try and prohibit the state from ever trying again. We have to be prepared for everything. And that's going to require that the people who vote for CalCare know what they're voting for and know how to protect themselves against the lies. And training activists with all of this info so they can go out in their communities and make sure everyone knows the truth. It's going to take a lot of deep organizing, and it's something that we want to provide to activists. And I think that's going to be very important. So I'm excited for all these things. And we're also going to, of course, be doing we're going to be IDing new supporters in key districts as we've been this whole time. So we will be doing our part as well. We have different groups like Healthcare for All Los Angeles, PNHP, that will be doing their part as well. And I know that all these different groups are going to be moving forward. Even though we're going to be doing slightly different things, we're all going to be working towards the same goal, which is passing AB 1400. And I think there's going to be plenty of places for everyone to plug in one way or another. I really do.
Yes, absolutely. But it is going to be all of us, all of you doing this, because we will see an unprecedented amount of money spent on the anti-AB 1400 stuff. You think Uber and Lyft did something? Wait until you see what big healthcare can do. Anyway, I want to go, Lynn, I did not forget about you. I see you had a comment about 10 minutes ago. Do you still have that comment? Lynn, are you there? You're muted. Okay, well, we can come back to Lynn. Oh, there you are. Lynn, are you there?
Yeah, I'm on my phone, so the microphone's really tiny. Anyway, I love your meetings. You are the only group in California that has meetings like this, that shares information, your activism and such. I live in Menlo Park, way north of you, and unfortunately, there's nothing going on here in regards to CalCare and stuff. But I have a couple. Medicare contracts out to insurance companies currently for their billing, and they're not allowed to change anything. It's whatever Medicare pays. So there is no agency that processes Medicare claims currently. So Blue Cross Blue Shield, I think, might be one of the insurance companies, because of course they have the skills. The claims processors have skills. My understanding is when CalCare passes, there are going to be a lot more claims because more people are going to be insured. And so I see, and maybe you already talked about this, but people like Gina will keep their jobs, and they probably are going to need more claims processors to process the CalCare claims. Dr. Bill and I are on a one payer states committee, policy committee, where I'm learning a lot. The two top healthcare experts, single payer, are Kip Sullivan in Minnesota and Dr. Stephen Kemble in Hawaii, who's been working on healthcare for years. Dr. Bill also talks about the three-legged stool, and it's kind of a long explanation with Kaiser and why Kaiser is fighting. When CalCare is passed, one of the legs is going to go away, the insurance part, and that's what Kaiser's pissed off about. But Dr. Kemble, like you've been saying, Ryan, and he says global budgets are the only way to go, no capitation, period. He also says for individual healthcare providers, that's fee for service, and that doctor would negotiate with the board on his salary. The capital expenditures, when you want to, or somebody mentioned something about building another hospital, I think. Again, that's the board that decides it. No group of doctors can buy an MRI if it's not needed in their area. So anyway, Ryan, you're phenomenal. I can't believe how much you're doing. I was a CNA activist years ago, nurse negotiator and stuff. So I watch very carefully what CNA and NNU do. And thanks so much for allowing me to speak on your committee.
And thank you, Lynn. Thank you for your kind words about the work we're doing. I appreciate it, and sharing your knowledge with us as well. That's what this is about. Each one teach one. We all know a little bit about a little thing. You know, I know a lot of bit about healthcare, but a little bit about everything else. Anyway,
Gina, I just want to say one thing. Lynn has been an awesome healthcare advocate for over 20 years, 25 years, maybe 30. So she's not new to the game, and she would be a great resource for us as well.
Awesome. Well, Lynn, you're welcome anytime. If you have anything you need to share, please let us know. And
also,
you know,
Gina, can I just say for Lynn, if there's not a lot going on in your area, Chang Sim, who I think is going to talk next, one of the things that we have going on in partnership with HCA-LA are trainings on how to present CalCare to your neighborhood council. This is such a brilliant thing because we're really building and inoculating from the ground up. So the more neighborhood councils that endorse CalCare, the more people that learn about it, then the more pressure it is for their city council members to support it. Then you've got your city councils endorsing CalCare. Then the assembly members are like, we're like, look at all your city councils endorsing CalCare. And, you know, so that's something that you can do. You can just go to HCA-LA.org and we'll connect you to the people who are training for neighborhood councils. And if there's not a neighborhood council in your neighborhood, you can go to the one next door. So we'll hook you up with something.
Thanks so much.
Appreciate it.
All right, so I'm about 10 minutes behind on questions, so I'm gonna power through really quick. Paul, you put a question in the chat about 10 minutes ago. Will hospitals, for example, mental health, be built based on the need for mental health hospitals to treat like drug addiction and mentally ill homeless? God, I hope so.
Yeah, I think that's the only thing to say. God, I hope so. It should be, and in theory it will be, but all we can say is they ought to be.
Yeah, awesome. I mean, like I said, it goes back to that need assessment. And if they're not talking the words need assessment on the board or in the committee, I might just have to go up there and kick some doors in, because we need to do some needs-based assessments like nobody's business. But that goes into why, you know, we're nurses, because that's the language we speak. And except when it gets twisted and turned around in the legislature, I'm like, what do you mean care coordination means capitation? No, it doesn't. Anyway, sorry, I'm bitter about that one. Okay, really quick.
There's a Mariana Aguilar. I think maybe you didn't see that she has.
Yeah, I was kind of like scroll. It keeps, you know, popping up, and I see that.
Yeah, she's been interested in hearing about mental health aspects, talking to my neighborhood about CalCare. And I know they will have a lot of questions, especially given how many encampments are in their neighborhood. So hopefully maybe we could tell her about talking points or what AB 1400 will do for people that need mental health care.
Yeah, go for it.
Yeah. So I think when it comes to mental health, obviously it's fully covered, but that's not enough, because if you don't have enough people to provide mental health care, you can have all the coverage in the world. So a few of the things that AB 1400 will do regarding mental health is, one, this is the same thing that that AB 1400 does to encourage more providers to move to areas where there's a lack of providers, specifically rural areas. And that's that the bill includes specific provisions for increasing the reimbursement rates for providers that practice in medically underserved areas. So if you are a primary care physician and you want to go practice in a rural area that has very little as far as primary care, you can apply for increased reimbursements over the normal rate. Now, why is that important? Because most areas of California have a severe shortage of good mental health providers. And there's a few reasons for that. One, because it doesn't pay particularly well. Two, because it's often not covered completely. And when it is covered, it's often covered kind of in a half-assed way. And then finally, there's a lot of stigma over mental health care. We can't ignore that as well. So while we can't necessarily eliminate the stigma solely through legislation, we can help by making it more available to everyone, which is a major part of it. And increasing the number of people who practice in the field of mental health and making sure that it's more available by allowing for increased reimbursement rates in areas where mental health providers are most needed. And Lord knows they're going to be needed, especially as we move forward further away from this godforsaken pandemic. Mental health is something that we aren't talking about nearly enough regarding, which is going to be one of the consequences of a year of lockdown. So yeah, it fully covers it and includes provisions for getting more people to provide it. I think that's the way to summarize what I've been saying.
Thank you. Chang Sim, you're up.
Yes, I have a question again about strategy, because Ryan, you said that, you know, we should inoculate it, not just for, you know, I mean, looking ahead, like if CalCare passes, we have to inoculate Californians against the, you know, anticipated action to overturn the bill by the medical industrial complex. So I'm wondering if what CNA or you think about what's going on right now, because obviously the people who are benefiting from the current system are not stupid, right? I'm sure that they're not just hanging back and saying, oh yeah, just let CalCare happen, right? You know, and then we'll tackle it when it passes. So I'm sure they are doing things right now that we are not seeing, right? So what is your thought on what may be happening right now on the quiet that we need to be inoculating our supporters, CalCare supporters against? You know, what kind of doubt, what kind of confusion is being spread right now that doesn't seem like outright opposition to CalCare, but effectively could be?
That's an amazing,
that was great.
Absolutely amazing question. So for those of you who were involved in SB 562, and I'm sure that's most of you, you will remember that when the bill was shelved, the Speaker of the Assembly put out a statement saying, I am a longtime single payer supporter and I'm encouraged by the conversation happening around SB 562. This particular bill is woefully incomplete. We're going to shelve it. The Senate should try again. That was what he said. That is what you are going to hear, or at least a variation of that, from opponents. Very rarely are you going to hear I don't support single payer from Democrats. You are going to be most likely to hear, I support single payer, but here's the very, very specific, nitpicky, wonky issue I have with this particular bill as to why I can't support it. And the problem with attacks like that is that they're very hard for the average activist to refute. The average activist doesn't know what capitated payments are. The average activist doesn't know the nuances of managed care. They don't know the stuff about healthcare financing, nor should they be expected to. So when they say, I support single payer, I just want to see this particular aspect fixed, how do you defeat that? Well, first, it's showing that there are answers, which is what we're doing today and what we need to continue to do in our communities and as large a scale as possible. Activists don't need to know every answer to every policy objection about CalCare. They just need to know there are answers. They need to know, and they need to be very mindful of framing. Because as much as we love to talk about the wonky aspects of CalCare, and as much as we need there to be these kind of conversations, for your average activist, they need to know how to reframe the debate. Because the average activist is not going to persuade a legislator by going into the weeds. They're going to persuade a legislator with the overarching themes of how this is the right thing to do. And then finally, and this is the most important part of the equation, not giving them a choice in the matter. Insurance company propaganda and money will only work on legislators insofar as they're more afraid of them than they are of us. The moment that legislators are more afraid of losing their job because single payer supporters will vote them out than they are about insurance company money, that is when insurance company money will lose. Which is why the answer is organize, 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 and inoculate, inoculate, inoculate. When we continue to reach out to new activists, bring them into the movement and shield them from misinformation, then you're going to see that money not work as well. This worked on the federal level. I've been in the room when Medicare for All activists, including Adi Barkan, were sitting with Salud Carbajal in Santa Barbara, talking about Medicare for All. They were inoculated and they were building community pressure. They had mayors on board. They had city council members on board. They had rallies in the districts. And Salud Carbajal got on board. Not because he suddenly decided that I'm now a supporter of Medicare for All. He got on board because the activists in his district gave him an offer he couldn't refuse. When we do that everywhere, we'll win. And I know it seems hard, but that is the ultimate answer for how we win. It's how we're going to get the bill passed, and it's how we're going to defeat efforts to repeal the bill. It's all the same work. Organizing, building momentum, building support, and shielding that support from propaganda. That's how we're going to win.
Exactly. And I think one thing, like I said, talking point when you are talking to that on the fence, moderate Republican or, elected official, reminding them that this bill has a fail-safe in it, which is if the shit doesn't work, I can't go live. Okay. So let me go explore the same way that you guys have been able to explore bailouts and everything else. This bill really just lets me start the exploration of building a single payer system in California, because it is written in there that if we can't get the money or if we can't get the system worked out, the board says no, it doesn't go. But we can't even try unless we get this bill passed. So truthfully, if the most honest of it, this doesn't mean that you're actually, that it will be single payer tomorrow. It means that now I get to go explore how to build it for the first time ever, by golly, man. So that's one thing that I like to do, because it gives them a little bit of safety, like, oh, okay. And then also what Sean Broadbent brought up, from DSA, was make it transactional. If you support this, I'll phone bank for you. If you don't support this, I'll phone bank for your opponent. They need those phone bankers. They need those grassroots, because if you've noticed, they can't just take all the corporate money anymore and not get called out on it. So that all these elected officials are all depending on grassroots support in some way, shape, or form. So when you go to them and you're saying, I'll host a phone bank for you. If you've got a little bit of money in the bank account, maybe you'll host a fundraiser for them. If they support and sign on to publicly, now that's how you get them, sign on publicly to AB 1400, like put it on your Twitter, put it in writing, put some money on it. I don't know, do it public. And that's how you can, also make it a little transactional. But those are just some things that I know that I've learned in the last couple of months about how we can get these people on board. But like I said, transactional with these elected officials, will definitely make it a lot easier. Really quick, I want to go to Maureen, and then I see Erika, and then I'll have to go down the rest of the chat. Maureen, you had a question about the CalCare committee that the board builds. Does it have any teeth, Ryan? Is that just to be cute, or is that actually going to have a little bite in it?
Yeah, mainly does the board have to take the advisory committee's advice?
So the way these arrangements typically work when you have advisory committees advising a formal government body is it's not mandatory, but the more you ignore them, the more you imperil your position on the committee. That's typically how it works. And while there's nothing in the bill to that effect, what I anticipate happening is that since the advisory board is made up of a wide variety of specialists, much wider than the actual CalCare board, who have more specific expertise, like as opposed to just the requirement to have like essentially one professional practitioner, you have more specific ones on the advisory committee. So you have more detailed knowledge about the multiple aspects of the single payer system. So the more you ignore the advice of the public advisory board, the more likely this board is gonna lose the trust of the legislators and get replaced. Now, obviously it's not a perfect solution, but it is a model that has worked in other aspects, including the carbon air board. There's these sorts of things exist elsewhere. So I'm hopeful. I guess that's what it comes down to. I think the structure of the bill overall is very solid. And I think that having that sort of advisory committee just also creates a lot of public pressure, because obviously all these meetings for the most part are required to be open. So if you have a public advisory committee say this needs to be done and the board does the exact opposite, that's probably something that's going to be run with, and it's going to look really embarrassing for those involved. So in there, and just to finish that up, with the exception of things that involve patient info, etc., these meetings are all subject to the Brown Act. So they're all going to be things that people will have access to.
Awesome. Thank you so much, Erika.
I see that James has a question. Go ahead and go to him because I've asked stuff.
Okay. James, so James asked, how do we appease concerns about government programs? James, do you want to elaborate on that? Or are you talking about like Medicare, Medicaid, people worried about losing that?
People like the concept of CalCare. They just think that whenever government gets involved in anything, it's going to be an unmitigated mess. How do we address that?
It's already a mitigated mess. But I was like, and done. I was like, have you seen the healthcare system right now? Okay, I'm sorry, Ryan, that's your question.
That's actually a very good answer, Gina.
And she's right. When I was in college, I was a competitive debater, and one of the fundamental arguments in a debate round is called uniqueness, meaning that if you attack an idea or a plan by claiming damages that already exist in the real world, it's not an actual criticism of the plan. In this case, saying that the government is dysfunctional and our healthcare system is dysfunctional, like that's not an argument against CalCare or this bill, because that's how things are right now. Now, that being said, it's understandable why people would feel this way. We have, other than the typical attacks on the California DMV, you also have the EDD, which has been a complete hurricane. So yes, it's a valid fear, and it should be something we should address. And the answers are, one, that there are, again, fail-safes in the bill. Namely, that it really increases the power of the actual providers as opposed to the current system. And the providers aren't the problem. So it includes some transfer of power from the top to those actually providing the care. And even though it's not a perfect answer, it does provide some reassurance that not everything is going to be a disaster. And at the end of the day, people just need to know that things are going to be better than the way things are right now. If you can make the point that right now, literally every aspect of our healthcare system is a complete mess, and then under CalCare, at least doctors and nurses will be able to decide what care you need and ensure you get it, and that any other chaos that could happen is going to be on the back end. It's that from my experience is enough to make people say, well, okay, I can understand that. But you're never going to convince people that a government program is going to be perfect, nor should you even try. All we have to do is convince people that it's still better than the mess we have now.
Well said. I think that's a very good way to say it. Erika, you want to ask your question?
Yeah. Oh my gosh, I have so many questions. I will start with one, and then if nobody else has other questions, I'll come back later. What would you say, Ryan, I've had this experience where somebody say is on the well-to-do side, and they have, quote, good insurance. Well, let me back up. So I know somebody who recently had a procedure, and they believe the bill. They believe the number on the hospital bill, okay? It was $40,000. They have really good insurance through a union, so they're paying like, I don't know, $1,000 out of pocket, let's say. So when they see that, they're like, oh my gosh, thank gosh, I have this insurance. But of course they're paying deductibles and copays, but they don't really pay attention to that. And then there's this sense of pride of, I've worked really hard for my family and I to have this insurance. And look at what the good job I'm doing. I just saved us $39,000. Do you have any thoughts on how to approach that, that person, or do we just not approach that person?
So to be clear, there's always going to be some people that just don't want CalCare, even whether their arguments are based on real world truths or not. That's not as important as the reality that there are some people that just from an ideological or from a position of their experiences aren't reachable. And that's fine. You can't convince everyone. You should still engage with them and try, but if it doesn't work, don't be discouraged about it. There are people who generally think that way. But I do think something that's important to emphasize is that most people don't realize that very few procedures in this country actually cost what the bill says it costs. It's entirely random. There's a reason why we pay the highest prices for healthcare in the world. And it's not because the quality of our care is that much better than it's everywhere else. It's that the amount that you see on that bill is oftentimes entirely random, with no connection to how much it actually costs to provide that service. So people don't realize just how absurd the American healthcare system is. And also talking about the union issue, people don't realize that in 10 years or so, those union plans won't exist anymore. Doesn't matter how hard they've worked, but healthcare costs are increasing way faster than union member wages are. There's a reason why every single contract negotiation, not only are you not getting a pay raise, but you are also being asked to pay a larger premium or have a higher deductible. A lot of people are getting deductibles for the first time in their amazing union healthcare plans because it's just not sustainable. And I don't think people understand that what you are enjoying right now, if we do not change, will not exist within a decade. So we have to take some action, and that will work with some people. It won't work with everyone, and that's okay. We need to convince as many people as we can that are reachable. And if they're not reachable, we still be polite and we still fight for them just as hard as we fight for everyone else.
Exactly. And yeah, just to add, I mean, with union healthcare, if the unions didn't have to spend so much damn time fighting for healthcare, they actually might be able to fight for your workers' rights, which is like telling you like safety. For example, so everything gets pushed to the bottom because they spend so much time having to focus on healthcare. And with that burden freed from them, now they can get to the nitty gritty and start fighting for your mental health, time off of work, different work hours. Sweden's using a 4-day work week. These are things that our union should be fighting for us for, but they spend so much time at the negotiating table just for healthcare. And so let's take that burden off of them so that they can get to fighting for things that are going to be more innovative, that will open up our lives and make us, give us a little bit more freedom from the persecution that is the capitalist workforce. Sorry. Anyway, James asked a question. So say AB 1400 passes, how long would the rollout be?
Great question. The answer is however long it takes for us to have the money to implement it. Gina mentioned a fail-safe earlier. That fail-safe is until the board of the CalCare program notifies the Secretary of Health and Human Services that the system has the revenue it needs to fully implement. The only parts of the bill that take effect are the governance parts. The actual implementation of delivery and financing of care does not take effect until the bill is fully financed. So however long that takes, and that's why, by the way, it's not important that financing be added to the bill right away. Because you can either add financing to the bill later, or you can just pass it in an entirely separate bill. It does not matter, because the bill does not need financing there to start implementing the governance. But it'll just essentially sit there waiting for it to be fully funded. So there's no risk in passing the bill without financing or these other aspects. That's really important to know. And it's really important that legislators know this as well, because this has been and will continue to be an excuse that they give to not move forward.
It is their security blanket. Like if Linus from Peanuts, that is their security blanket. That is their thing that they go to, the finance, the finance. And that's why it is so important to drive home that specific point, because every single legislator you talk to, whether even if they may support it, they are going to come to you about this one particular thing. Why? Because it's the easiest scapegoat out there. It's the scapegoat that looks pretty and fluffy and just hopping around the field, and you can just easily grab it and take it. And if you are not ready to answer that and know in the bill that we can't move forward, we can't implement without finance, and we just need to be able to build it. We need to get the okay to get the governance going and all that stuff. That's what AB 1400 allows us to do. Then we'll never be able to open this door, and we'll continue to have to knock on your door, because SB 562 turned into AB 1400. AB 1400 will turn into something else, and you will still not get rid of me. So just pass AB 1400 and make me shut up a little bit. Anyway, Erica, you've got another question?
Another question? I have so many questions.
Okay. What's the most burning one?
I guess the most burning one is, well, I guess about what you just said, Ryan, but aren't we already on the path for them to add financing to the bill? And I mean, can you talk a little bit about that? And, how can we be, I don't know, how can we be most supportive if that is the path that we are on? Or could we is there still an opportunity to have this bill go through as a policy bill and do financing as a separate bill? And then if we did financing as a separate bill, what are the risks there? Thank you.
Great questions. So when it comes to the current situation regarding financing, it is being talked about. And by the way, I'm speaking from CNA right now. So I'm giving you the info that I can give you the best that I can. Financing is being discussed right now by the authors and various stakeholders in the bill, of this bill, and among the legislators. And it's possible that financing could be added to the bill or done in a separate bill, as as AB 1400 currently calls for, separate legislation. I'm not sure, we don't know what that's going to take. This is going to be a long process, but at the end of the day, I think as activists, the most important thing that people can do is not get bogged down on the need, because it doesn't matter whether the financing is added to the bill, or it's done in a separate bill, or it's not even done this quarter. It's this term. It doesn't matter. At the end of the day, AB 1400 is a bill that is implementation ready as is. The only question is the right way to do financing, not how to do financing. We know the bill can be financed. There was a study on 562 that proposed a very specific financing mechanism for how to pay for that. There have been white papers on the national Medicare for All bills with giant menus of different mix and match options that could have fully funded Medicare for All in 1,000 different ways. We don't need more studies to know that we can pay for Medicare for All, or CalCare in this case, in a way that saves money on the macro level and on the family level. The only question is how we do that. And we can't allow ourselves to get bogged down in that debate, because we are, at this point, we talked about distractions earlier. How do you do financing, blah, blah, blah. The bill doesn't need financing to take effect. And then to answer your final question about what are the risks of doing financing in a separate bill, The risks are that we don't pass one this quarter and the bill just sits there until we finally do. There's no risk as far as long-term structure, although I guess you could say that it gives the insurance and drug companies more time to build a campaign to take it down. But at the end of the day, there's no reason that financing can't be done one way or another. In fact, if you want to talk purely legislative, and I'm taking off my CNA hat and talking about from my point of view right now, if you want to talk about the easiest way to do it, a financing bill is going to take a 2/3 vote to get through the legislature based on legislative rules. So it doesn't make sense to add financing directly to AB 1400 if you don't feel like you have a 2/3 vote. So it makes more sense to do it separately, as far just to ensure that the governance can at least take effect. That's how I see it anyway.
Thank you, Ryan. And I think, like I said, emphasizing and really driving home that separation there, because like I said, this is their security blanket. They're going to use it. They're going to continue to use it. And also telling the public that they're being bamboozled. If your legislator says, well, it's because there's no financing option, it is our job to say, this is not about the financing. This is about building the system, and the financing is separate of it. And if they tell you that, they're lying, or I don't want to call people liars. They're just not being fully aware of what this bill really is. They're incompetent. Anyway, Betty, you have a question.
Yes, I do. It's about our about Kaiser. It's a question that has probably been asked in other sessions, but since Ryan's here, I figured I'd ask it. What happens to Kaiser and with AB 1400?
It still provides care, it just stops paying for it. Like I said, you get all the benefits of Kaiser with added freedom of being able to jump ship the moment you find someone better. That's basically what it comes down to. It's really that simple. Kaiser, we have the three-legged stool that Dr. Bill talked about. You have the fact that Kaiser provides payments for care, it provides the practitioners or the providers, and it provides the facilities. It'll still provide two of those things, it just won't pay for them anymore. That's really the only change, which to the average person, if you're someone who isn't involved in this process and you are someone who goes to Kaiser, the only thing that'll change is you can go to Kaiser and show them your card and get the same exact care, but now you can go elsewhere. The system will literally not look any different to you.
And if you get admitted outside the Kaiser system, you don't have to worry about being schlepped about from wherever you are to a Kaiser hospital. They will do that no matter what. As soon as you're medically stable, to Kaiser. Anyway, I do a lot of anyways, I'm sorry. But I wanted to go there. It looks like there's a question from Facebook. Thank you, Paul, for adding that there from another Paul Colpadilla. He asked, but isn't Ash Culver rewriting the bill now to reintroduce it with financing?
Great question. Ash is having conversations about adding financing, absolutely, but that doesn't necessarily have to come in the form of an amendment to a bill. There are other ways to go about it. You can do a separate bill, and you can, or maybe just decide not to link them. You can actually amend bills to say that this bill will only become effective if this other bill passes too. I don't think that's necessary, but it's something that they can do. And like we talked about, it isn't necessary that it has to come here. And the language of AB 1400 includes an intent of the legislature clause that says it's the intent of the legislature to enact legislation financing the bill. So that's already there. So while they are talking about adding financing, that doesn't necessarily have to come in the form of an amendment to AB 1400. And like I said earlier, it may not make sense to do that if Ash is really worried that we don't have a 2/3 vote in both houses, because there's no reason to tank the policy for financing that can come later. That's just my analysis, though.
Thanks, Ryan. I don't see any other questions, but I do have a question that it may take a little time to explain if it's explainable. We got into this conversation before about but like the pay. For us healthcare providers, which I know healthcare provider in the bill means like the hospital system, but I'm saying like doctors, nurses, techs, all the way down to your environmental service people, because they matter too. You don't know how much EVS really matters in the hospital until you have someone with explosive diarrhea. Anyway, I wanted to ask that, so we know that in AB 1400, they can't pad executive accounts. They can't pad the CEOs with bonuses and things like that. But is there something that will stop them from, like, let's say, cutting pay for nurses or doctors or, you know, staff in the hospitals, because now, granted, the global budget is there, but, you know, how can pay be protected so that we're not getting our pay slashed so that the hospital can still keep whatever cushion they're living on now?
So that is an amazing question. And the only answer that I can give right now is you have the same protections that exist under the current system. And I know which is one, unions, because that's why provider pay in California is higher than the net average, especially if you're a nurse, obviously, but you also have technicians that are unionized by other unions that also make more here than they do elsewhere. So unionization is a major aspect of it. And also the fact that a global budget is a very transparent thing, in the sense that a hospital has to submit a proposal and enter into a negotiation. A hospital can't just be like, we need this much money to pay these nurses and these technicians and these doctors and so, and then halfway through just be like, nope, we're going to cut your pay and pocket the rest. That is not going to work. That's actually that'd be a violation of a contract. So that couldn't happen. The global budget inherently prevents that. So then what would have to happen is that the hospital would then have to go to the system for when it's time to negotiate and say, hey, this is how much we're requesting, but we want to pay the technicians a little bit less than they made before. And then they'll be like, wait a minute, why? And then they're gonna be like, they can't just be like, well, we want to pocket that money instead. That won't work. So the transparency in the global budget is a major form of protection, in the sense that they don't have the excuse of trying to cut pay, because at the end of the day, it's taxpayers that would be paying those global budgets. It wouldn't change compensation, so it removes that incentive. So they wouldn't be able, so basically it's structured in a way to where they don't have the ability to just decide to cut the pay and then take that money and pocket it. That's possible now. That's not possible under a global budget.
Thank you. Yeah, I know you brought up the unions, but you know, the only thing that's unfortunate is that because of, you know, how the unions have been gutted over the years, over the decades, you know, I mean, there's a lot of healthcare jobs that aren't unionized, and, you know, and it's because, well, I mean, you can't even get employees to really want to unionize because it's the fear of retaliation. And it's kind of sad that we're talking about this, but at the same time, it's a very realistic thing. So I want to acknowledge we are coming into our last 15 minutes here. Erica or Paul, do you guys see any questions in Facebook land? No? All right. Anybody have any questions here?
I have still, of course, more questions, but
Okay.
I would like other people to have an opportunity to ask their questions. So.
Awesome. Well, I'm opening the floor. Maureen, you have a question?
Yeah, I would like to ask Ryan. Ryan, what is the best that we can do with here in Los Angeles to support CalCare? What I mean, is it visibility? Is it having education panels? I mean, you know, outreach, all of the above. I mean, what is, in your opinion, like, what are the most effective ways in which we can participate in the movement to get AB 1400?
So the most I can tell you is to continue bringing new people in. And I know that's very broad, but every group has different mechanisms of doing that. And you all have been doing such great work when it comes to the education aspect and the outreach and all that. I think that every group, the main thing that they can do in whatever way they deem best is to continue to find new people and bring them in, because the more activists we have, the more people we reach. The reach of just a small group of people doesn't go that far, but every person we reach reaches their networks. Every person that from those networks that becomes an activist reaches their networks. It's like a healthy version of COVID. The more people get it, the wider it spreads. So instead, only in this case, we're not killing people, we're saving lives.
But when we get all those people, do we want them to be contacting their legislators? Do we want to urge the legislators to get on board? I mean, when we get these people, what do we want to ask them to do? What's the most important thing?
I definitely think we want them to ask their legislators to get on board. At the end of the day, that's what it comes down to. Legislators have to pass the bill. And they care about their constituents. And what they have to say, in the sense that if they piss off too many of their constituents, they don't get reelected. So the more of their constituents start caring about CalCare, the harder it is to avoid, because that's the thing. And I want to emphasize this because it's very important. Every single poll that says that CalCare or single payer has a lot of support should be looked at as a reminder that we do not have the power we need. Because if you have any policy that has 60, 70, 80% approval, but isn't being taken seriously, that means that it's all talk. No one is considering this issue important enough to stake their vote on. We saw that in the presidential primary, where Joe Biden won states where the overwhelming number of Democrats said, yes, I support single payer. Clearly, it wasn't important enough for them to vote that way. We see the same phenomenon here. So until we have people doing more than just saying they support it, we're not going to get their ear. We need to continue to build real power and have people willing to actually do things like promise to support a primary challenge, or to withhold a vote, or to continue to do legislative visit, whatever it may be. People need to be willing to put real pressure on legislators in order for us to win. And whatever different groups, Healthcare for All LA and every other group, the best that they can do to make sure people become active is, I think, the best we can do. And that's really all I can say, because every group has their own way of doing things into that regard. But I think that's the direction we have to go.
Thank you. And then Erika, you have a question from Facebook?
Yes, I do, from Chris Shimizu. There are organizations that say they support single payer who have not endorsed AB 1400. Why haven't they, and what can we do to get them on board?
So
Go ahead.
Go ahead.
No, you go first.
Just ask them. And you won't always get the right answer, of course, because there's politics involved sometimes. Sometimes there's back-end conversations with whatever it may be. They may be under insurance and drug company pressure. We may never know the real reasons, but we still need to engage with these groups. And it may be that they just haven't gotten around to it yet. It may be that there are political considerations, but I think that it's not helpful to assume the worst until we have dialogue with these different groups and figure out what specifically is the reason. Because by all measures, AB 1400 is the best single payer bill that has been introduced at the state level. So if this isn't good enough, we need to know specifically why. It may be a good faith reason and it may not be, but we don't know. We need to figure that part out in order to do effective outreach. So I would say, before we come to any conclusions, ask them.
Ryan, on that note, so HCN comes to mind. They are a coalition of single payer, advocates. Full disclosure, HCA, the state, is a part of that coalition. And so one of the things that we've heard is that they are doing a different strategy, that their strategy is to focus on Governor Newsom writing a letter to President Biden. It's the same letter he wrote to Trump to give California the waivers to implement single payer. And I guess my question for you, Ryan, this is what comes up for me if I had a chance to go back and ask them, is I understand different strategies, but you can endorse AB 1400 and still pressure the governor I don't see how that they're mutually exclusive, and I don't see, to me, not endorsing AB 1400 is damaging. So that would be my thing. I don't know what you think about that. And then also, when I looked at the waiver process, it seemed clear to me that you need a bill to get a waiver. So so that also makes me not understand. Like, I'm all down, support the governor to get the waiver, but endorse AB 1400 at the same time. Do you have any possible insights on that?
So I'm going to start by saying that I have no intention of impugning the words or the motivations of anyone in the single payer movement, because ultimately this is a movement that is about justice and is about fundamental health and dignity of all Californians. And I'm not going to weigh into the motives of different groups, including Health in California Now, as to why they are doing what they're doing. That being said, I will give my thoughts on strategy and solely strategy as to why we are all in on a bill as opposed to the governor. And I'm speaking it from CNA for full disclosure. You are right, and I actually did a Facebook live stream with Carmen Comsteve from CNA, who, by the way, wrote most of AB 1400. She and I did a live stream talking about the waiver process, because we had a lot of our volunteers confused about what was true and what wasn't. You're right, Erika, that you cannot request, well, you can, I guess, technically request a waiver if without a bill implemented, but it will be rejected, because both in federal law, like statutes codified into law, and in terms of regulations at the federal level, statute and regulations, you do need to submit legislation with your waiver application authorizing you to implement a single payer system. That's AB 1400. If you don't have that, they can't approve the waiver. So that's true. You do need a bill first, but it goes a little bit beyond that. I fully support the idea that the governor should get behind the bill, of course, because he needs to sign it. But here are two important things to keep in mind about the governor in the terms of this process. The first is that the note or the letter he sent to Donald Trump was actually not a waiver application. The letter he sent to Donald Trump was him saying that he wanted the federal government, Congress and Trump, to create a new waiver to make the process easier. That's not an actual waiver application, and it's not necessary. All necessary authority to implement CalCare is currently already in federal law. So submitting that letter wasn't worth the paper it was written on. In this, if your goal is to apply for waivers, it was great for messaging, saying, "Hey, this is what I want to do," but it didn't have any policy impact. Now, I will say that there is a downside to a governor-centered approach, and the downside is this is something that I've been concerned about on a personal level as well. We don't want legislators to have an excuse. I've already heard from multiple legislators personally that their hands are tied until they have waivers to do the program, when in reality it's the reverse. A campaign that focuses too heavily on the government in lieu of a bill gives legislators the avenue to say that, well, we can't do anything until Newsom acts first, so go for the governor first. So that's not correct. Legislators can't shirk their responsibility to pass a bill, because if we don't have a bill, we can't get waivers. So I think it's good to ask the governor to get on board, but we need to keep in mind that that should be in addition to and not a substitute for legislation, which is why I think that any group that does support guaranteed health care for all, single payer in California, even if they think going the governor is the right way, I think they should get on board AB 1400, because you literally can't do it without a bill. That's, I think, what it ultimately comes down to.
Thank you so much, Ryan. I don't know, this question may go too deep, but in the last few minutes before we close out, Last question from Facebook from Paul Copadilla says, because of Prop 98 and the GAN limit, it certainly looks like we will have to win single payer at the ballot box here in California. Is CNA prioritizing AB 20 and much better, stronger California Disclose Act so that we have a fighting chance? Last question of the night.
I don't think we've actively endorsed them. I'll have to look at our endorsed legislation. Typically, CNA endorses legislation directly related to the work of nurses because that's their primary focus, and we only have so much resources to put into lobbying for bills. But I'm sure if you ask, we would support that kind of thing. I'm not on GR, so I don't have any insight onto that. What I can tell you, though, is that we need to make a slight correction in terms of verbiage there. We don't need to go to the ballot to implement single payer. We need to go to the ballot to implement financing of single payer. Remember, those are very different things because you can pass AB 1400 and not run afoul of Prop 98 and the GAN limit at all. Once you implement financing, you may need to implement or approve financing through those processes, and you may not. It all depends on what legislative analysts and what the courts decide. But at the end of the day, Prop 98 and the GAN limit, just like they weren't excuses to not move forward on SB 562, they're not excuses to not move forward on AB 1400.
Thank you so much. So guys, this is wrapping up our CalCare office hours. I want to thank you, Ryan, for coming and dropping your knowledge and guidance with us. I truly appreciate it. And also, if you have other questions, feel free to, send us an email. We'll drop our Healthcare for All email in the chat on Facebook so that you guys can see it. And join us next weekend. We do this all the time now. It's becoming a normal thing. And it seems like we're the only organization in the state doing this. So please join us, come and ask your questions. And lastly, it is 7 o'clock, but one thing I want to do is it's Memorial Day weekend. And we know we usually spend this time to honor our fallen soldiers. And, I do, but I also want to honor our fallen healthcare soldiers. We lost a lot of nurses and healthcare workers during the war against COVID-19. And while that war was not bloody, well, it kind of was, but there were not bombs being dropped. You didn't see missiles coming from, the sky. It was a very invisible war, something that you couldn't see, something that the enemy was something so microscopic that it was hard to identify. And so it's really hard to feel that you were at war, but we were, and we still continue to be. And unfortunately, we've lost almost 595,000 Americans. This isn't global numbers, it's 595,000 Americans to COVID-19. So on this Memorial Day, I honor our fallen soldiers, but I also honor my fellow fallen healthcare workers, and I honor everyone who has lost someone near and dear to them during this COVID-19 pandemic. And with that being said, I want to thank you once again on behalf of Healthcare for All Los Angeles and PNHP for joining us for CalCare office hours. You guys take care, stay well, and we'll see you next Sunday. Bye.
Thanks, Ryan.
Thank you.